Okay, everyone, this lecture is going to be kind of going back and forth between the handout that I sent you, and then I will also send you these application exercises that are up on the screen. This lecture is more of an active lecture in the classroom setting, so we'll see how this goes. All right, the first thing that I'm going to talk about is cerebral palsy. You can see our scenario here. We have a 3-year-old child diagnosed with spastic quadriplegia due to cerebral palsy. They're admitted to the pediatric acute care facility with pneumonia. This is the child's 3rd bout of pneumonia in the past year. The child uses a wheelchair and has involuntary movements of both arms and spasms of both legs when passive range of motion is attempted. He makes unintelligible attempts at speech, although his parents can understand some of what he's trying to communicate. His tongue moves continually within his mouth, and it takes about 1 hour to feed him. Weight charts show him in the 5th percentile for weight in his age group. There are 3 different types of cerebral palsy. Spastic is the most common type. The other 2 types are dyskinetic and ataxic. Cerebral palsy also is on page 1455 in your chapter. Some of the causes of cerebral palsy are existing prenatal brain abnormalities, birth asphyxia. Postnatally, what we see a lot is a lot of shaken baby syndrome coming in, and as a result from being shaken, they do have cerebral palsy. Bacterial meningitis, viral encephalitis, and motor vehicle accident can all cause cerebral palsy. Those are some of your common ones. Okay, let's see. Our first question is, what is the probable cause of this child's recurrent pneumonia? Now, throughout this case study, I'm going to tie in all of the issues that we worry about with our kids with cerebral palsy. And if you go to the big handout that I already emailed you when we're done with this, you will see all of these other issues on there. I just kind of combine everything for lecture. Obviously, the probable cause is that the child is likely inhaling foreign bodies, such as food or drink, and introducing bacteria into the lungs. This is due to swallowing difficulties in constant open mouth that we read about in the chapter and in our scenario. So they're at risk for aspiration and also at risk for ineffective airway clearance. So one of our issues would be airway clearance, and your interventions for your airway clearance would be suctioning, oxygenation, feeding and positioning techniques, prompt and aggressive treatment for any upper respiratory infections, because we are thinking that they aspirated and we don't want that to turn into pneumonia. All right, number 2, lists 3 high priority nursing diagnoses for this child. What I've come up with is imbalanced nutrition, impaired physical mobility, and pain, to name a few. When we talk about imbalanced nutrition, it would be less than body requirements. We see where the child fits on they're in the 5th percentile for weight in his age group. And some of our interventions for that imbalanced nutrition would be a high caloric diet. Don't forget, these kids have increased muscle tone. So they have increased muscle tone. Their legs are constantly scissoring when they're in so their legs are crossed and their toes are pointed. And if you guys think about your muscles, if you tense up your muscles, you're going to have a higher caloric need. It takes some exertion to tense up muscles. So if their bodies are constant in this state of constant muscle tension, it increases their caloric needs. We want to make sure we're giving them easy to chew foods, utensils to help them eat, relaxed meal times. This isn't the time where we worry about their manners at all. We are just wanting to promote them to be as functional as possible. And don't forget, anytime with nutrition, we're always monitoring intake and output, and obviously monitoring their weight. And again, the degree of cerebral palsy will determine, can they feed themselves? They might not be able to. So again, don't forget, we're always looking at their developmental age. especially with this patient population, because it never matches the chronological age. All right, your next issue is impaired physical mobility related to neuromuscular impairment. Again, this is a neuromuscular dysfunction. So when we look at the impaired mobility, some of your interventions here would be to promote locomotion. We can do that either by using braces, get physical therapy involved. We're obviously going to use our play to promote locomotion. The child may be in a wheelchair. Again, really just depends on the degree of the CP that we're seeing. If it's an infant, make sure that we're doing infant stimulation. There are some medications that we can do to help relieve that spasticity. A baclofen pump is one, and also they can use Botox in this patient population. And again, it helps relieve that spasticity. Our next issue is pain related to involuntary muscle movements, and again, treatment for that muscle spasticity. And your interventions for pain are just to make sure that you're monitoring for pain before and after medication, and using the less potent pain medication that we can. So the least amount of drugs while receiving optimal benefit from that. All right, number 3, the child has a G-tube inserted for feedings during this hospitalization. He's receiving bolus feeds of 60 mLs over 20 minutes every 2 hours during the day. How should the nurse manage these feedings to be sure the stomach is emptying well and the child's risk for aspirating excessive feeding is decreased? Again, why are they on these feedings? Because kids with CP have tongue thrust with difficulty swallowing, and they also have difficulty sucking. So if they're having a hard time eating, again, we're looking at poor weight gain. One of the things that we do for these, anytime we feed, hopefully their feeding is on a pump. We use a pump to regulate the volume and rate of feeds. Before we feed them, we want to check for residuals. You want to make sure they're in a good position, so position them on the right side or in a Fowler's position. That does help prevent aspiration. Okay, next is list at least 2 safety precautions that should be taken with this child to prevent injury while he is hospitalized. Give a rationale for each precaution. And obviously our issue with this is risk for injury. Some of the interventions we could use a safety helmet to prevent any head trauma. We could institute seizure precautions and put an anticonvulsant on if they are having seizures. We need to adapt the room to the needs of the child, so basically child-proof the room, and to make sure we're making that room as safe as it can be. They have individually designed chairs with restraints in them to, again, help with locomotion. We think about if they are restrained to a chair and or bed, we obviously think about their skin. So again, there's protective coverings on these chairs, and there is restraints to keep them in place. We don't want to have any injuries. Oh, I forgot to move down my sheet, sorry, but I will send these to you guys, you'll have them. All right, number 5 is the last question here. Lack of which of the following is a warning sign of CP in a 3-month-old infant? It would be C, holding the head upright. That's an early sign of CP, poor head control or head leg, at or often around 3 months of age. Some of the other things that we see with CP, we see persistent neonatal reflexes, an obligatory tonic neck flexion. Associated problems with CP, 30% have some sort of intellectual deficit, sensory impairments, ortho conditions, dental problems, seizures. 50 to 60% of all cases, we do see a damaged cerebral cortex. Some of the other issues that I want to talk about, we talked about airway clearance, we talked about nutrition. Let's talk about risk for injury. We already talked about risk for injury, sorry. Sensory perceptual issues. We want to do screenings. How is their hearing? How is their vision? Do we need glasses? Do we need hearing aids? Again, pretty much this whole lecture, you're always thinking about how can I maximize this child's capabilities so they can lead the best life that they can. We talked about impaired mobility already. The other thing I do want to touch on is self-esteem disturbances. Again, whatever accomplishments they do, we praise those accomplishments. We do encourage independence. Again, that is our end goal, is to maximize their own capabilities. Make sure that we're fostering friendships with children that have similar problems. Make sure we're meeting educational needs, and make sure we're offering a wide variety of life experiences. And again, we can always throw into anything that we talk about in PEDS. I've said it a million times, there's always a support group, and there's usually a camp for every disability or disease process. And obviously the other thing that we're always monitoring and expecting with kids with CP is developmental milestones will be delayed.